Hello, my name is Jonathan Reimer. Welcome to Smart PT. Today I want to talk about TMJ management from a manual therapy perspective. So we'll get a lot of referrals for TMJ dysfunction. There are a few things to consider when you're assessing and treating for TMJ dysfunction. Basically, the upper cervical spine is very involved in alignment of the TMJ. So I would encourage you all to look at upper cervical mobility, alignment, muscle tension when you're addressing TMJ. I'd also encourage you to look at TMJ mobility itself and muscle activity around the TMJ. So traditionally we think of the muscles like the masseter, medial lateral pterygoids, and the temporalis, the muscles of mastication, and their activity around the TMJ. I've recently been informed about a chain of musculature from the upper cervical spine to the mental fossa in the front of the mandible. This chain includes the superior pharyngeal constrictor and its attachment, fascial attachment to the buccinator, and another fascial attachment to the orbicularis oris. I've had good success in addressing tension through that muscle group. The theory by the practitioner who brought this to my attention, Dr. Mariano Rocabado, was that that muscle is actually capable of producing a high degree of retraction force on the jaw, up to 5 kilograms on their testing, which creates a lot of compressive force at the joint. He further theorized that activity through the masseter and those other muscles I mentioned earlier of mastication is more protective. So the idea is to release that chain of muscles if they are tight before trying to address masseter and temporalis and pterygoid overactivity. Otherwise, you're leaving the joint relatively unprotected from the forces of that myofascial chain. Obviously, we need to look at TMJ mobility as well. A difficult thing with the TMJ is determining whether or not one side is hypermobile or one side is hypomobile. That comes through some experience of testing, unfortunately, so it's difficult to convey that in a message like this, but I'm happy in my courses to train people how to recognize those differences. So basically, when the TMJ is at rest or when it's opening, we may see deviations, and that might be due to that myofascial activity I talked about before, or it might be due to actual joint dysfunction. So as you're watching the TMJ open, you may see a deviation to the right, for example. That could indicate that the right side is hypomobile or the left side is hypermobile, in some cases a combination. So what you would need to do is address the mobility on the right side through either distraction or anterior inferior glide if you felt that it was hypomobile. And if you felt the other side was hypermobile, what you would want to do is work on stabilization exercises. I like simple exercises like isometrics into lateral deviation towards the side that's dysfunctional. Sometimes we'll also see disc dysfunction, and that is usually recognized through opening clicks. They'll tend to be a little bit earlier in the motion. You may actually see locking as people try to open. Typically, I find that hypermobile joints can click as well, but they tend to click a little further towards the end of the range of motion, whereas if there's a dysfunctional disc blocking the path of the condyle, then you will see that click a lot earlier in the movement. Discs are another tricky thing to fix. Again, it's not something that's easy to address in a message like this, but I'm happy to train people on how to try to fix those types of problems in my course. You can learn about TMJ in both the extremities course through Smart PT and the advanced upper cervical course.